right, good afternoon, everyone. And of course, good morning to our friends joining us from the West Coast. My name is Deanna Fenton, Program Manager here at the Alliance, and it's my pleasure to kick off today's discussion on data-driven performance. Now, we'll be joined today by our presenter, Janice Whaley, Chief Executive Officer at Donor Network West, who will share with us some strategies that her team has implemented to increase the volume of organs transplanted, going from 0 to 92. I'm sure you're all very eager for us to go ahead and get started, but before I turn the floor over to our moderator, I would just like to share some key reminders regarding today's program. Now, upon joining us for today's discussion, you may have noticed that your audio lines have been muted. Please note that your lines will be muted for the duration of today's discussion. That said, any questions or comments that you have will need to be submitted electronically using the Zoom chat feature. For those of you who submitted questions during the registration process, please know that we've done our best to compile your questions and we'll have our speaker address them throughout the course of her presentation. Now, should you have any additional questions, please feel free to submit them using that chat feature. Now, for anyone curious about continuing education credits, please note that there'll be no credits offered for today's program. However, you will still have an opportunity to claim a certificate of attendance and provide us with your feedback through our post-event evaluation. Following the conclusion of today's conversation, you will receive an email from us with outlined instructions on how to access that online evaluation. And as an added note, we will be recording today's presentation. So if you or a colleague is interested in viewing the discussion at a later date, you can always access the on-demand recording on our website at organdonationalliance.org. There, you'll also find information about any of our upcoming programs, and we'll have the opportunity to register for any programs of interest. Now, without further ado, I'd like to go ahead and begin today's program by welcoming our moderator, Amanda Habermill, who serves as the Manager of Hospital Development at Connect Life. Amanda, it's always a pleasure to have you with us, and at this point, I'll go ahead and turn it over to you. Thank you.
Thank you, Deanna. It is my honor to introduce today's esteemed speaker for a relative and timely topic. Janice Whaley serves as the Chief Executive Officer of Donor Network West in San Ramon, California, the second largest OPO in the U.S., joining the organization in January of 2019. 4 months after her arrival, the organization has moved well above the national average in recovery metrics. Her leadership, advocacy, and operational efforts in both the state of California as well as the nation overall serve as evidence of her passion. It is now my pleasure to turn it over to Janice.
Thank you very much. And we'll go ahead and get this screen up, I think. Okay, it really is a pleasure to be here today, and I'd like to thank the Alliance for inviting me back to speak. And I also want you all to know that although we have seen a lot of increase in our volume and we've saved more lives than ever before, our OPO is still on a journey, and I'm confident that our best is yet to come as we fine-tune and focus on our efforts in closing gaps. And so part of that is what I'm going to share with you today. The first couple of slides are going to kind of take you back to my prior presentation, which was a high-level presentation about what we were able to accomplish in 2019. And it will set the stage for what I'm going to share with you today. I'm going to be able to give you more details on actually what we did to show the improvement and to increase the amount of lives saved. So before you start the journey, you have to know where you are. And that was really important. When I arrived, I had some questions. How are we doing? What is our volume? How many patients are we really getting off the list? And so in looking at that, one of the most important things that needs to happen is that you really need to look at your data. You really need to understand what's going on from a data standpoint. And so what we decided to do was take a sobering look at our data. We did benchmarking. We looked to see where we were at from the perspective of per total deaths per 10,000 deaths. That was one of the ways in which we in the past have looked at our data. We know now we have a different metrics that we use, but we looked to see where we really started, where we were at. In the past, we had kind of compared ourselves against ourselves. We had not looked at ourselves compared to other OPOs in the country. And I think that's really important. And so as we did this, we realized that we were at the bottom of the quartile, third and fourth quartile in the nation amongst the 58 OPOs. Okay. So my approach to getting a handle on starting to figure out how we could get better and improve was benchmarking, keeping it very simple, focusing on volume and comparing apples to apples. So historically, we had always looked at how we were doing currently versus historical. So donors, total donors and DCD donors, and then organs transplanted, total and organ specific. What we were not doing was benchmarking against all the 58 OPOs. And so when I initially shared this with my board of directors initially, and then my team, they were shocked at where we really were. And one of my team members commented to me, well, there's nowhere to go but up. And so everybody realized where we were and also saw what the opportunity was for us to improve. And I have to tell you, I'm very proud of this team because change was not foreign to them. There had been a lot of change going on. And here I come in as a new leader and I'm looking at more change. And so I'm very proud of the work that they were able to do. One thing that was consistent throughout was that there was passion and there was commitment to mission. And so some of my team members are on the call today, and I want to acknowledge the hard work and their ability to embrace more change and see that we were able to save so many more lives is incredible. So I want to thank them for that work. But benchmarking is where we started. Even before the new CMS measures were in place, we were looking for ways to identify what can we do better and how do we go about doing it. So we realized, based on the data that I just shared with you in 2018, that we had a lot of work to do. And I'm happy to say that we did it. And what was so incredible about it is that, you know, I probably would have been happy with, 30 or 40 more donors, but we almost did 100 more donors in 1 year. What took 17 years to do in the history of Donor Network West. And it's never been done in this country. So in the history of transplantation, there's never been an OPO that has had a 92 organ donor increase in 1 year. And I'm pleased to say that our team did that. And in doing that, we saved so many more lives. And I'm happy to know that there are people that are home with their loved ones because of the work that we did. So what actually happened during this time? So this is a slide that we're most proud of. It talks about what actually occurred in 2019. So as you can see, we did 29% more donors. There was a 14% increase in organs transplanted. There was a 12% increase in livers transplanted, 26% in kidneys, and so forth. Our biggest growth was in DCD. We did 112% more. We almost doubled the amount of organ donors that were DCD donors. And so kudos to the team. Those are not easy cases. I know everyone on the call is aware of that. And so the work that was put into making that happen was incredible. And I really appreciate the work that our team did. So how did we do it? And that is the question that a lot of you requested that I come back and talk a little bit more about in detail. And so I'm going to do that. First was benchmarking. As I shared that with you before, we realized that, hey, we were really in the bottom of the quartile in terms of metrics. There were a lot of OPOs that were doing better. And what could we learn from those OPOs to help us to do better? And what best practices could we look to improve our performance? Leadership is really key. When leadership is absent or casual, uninspiring, applications of best practices and accountability for results are simply a no-show. So leadership is key to your success in this endeavor. Content expertise, that's another area of opportunity. Knowing it's one thing to know, but you also have to know how to apply known best practices. And so it's very important that people understand that. And then work paired with focus. You know, best practices that we have in our communities, they don't change, but implementation and accountability for outcomes does. So just knowing is not doing. And it's very important that we are able to not just know, but also do and apply these best practices. So I'm going to talk a little bit about each of these so you can kind of narrow down how we actually did things. So with benchmarking, this is what I shared with my board and my team initially when I came on board. In 2018, this is where we were at as far as it looks like we're closer to the 4th quartile. And we moved up to the middle of the quartile in 1 year, which was huge. And again, my team gets all the credit for the hard work that went into play here. But it was amazing to see the growth that we went through to get there during that time. So in DCD donors, though, there was an even more of an increase. You know, we were totally in the 4th quartile when it came to DCD donation. And as you can see, we moved up very close to the national average in that category too as well. And so the comment from my team member that there's nowhere to go but up is really true, because we had to find a way to refine our practices, to fine tune our practices, to look at where our gaps were so that we could get better. And we did that. And I will be honest with you, that first year, a lot of this was done organically and sometimes blindly. But we knew that there was more opportunity. And it was during our 2019 and 2020 that we really started honing in on gaps, using data to drive where we wanted to be. And so I'll be talking about that a little later on too as well. And leadership. And as I said to you before, your staff will carry the water if and when there's inspired leadership, present leadership in real time. Leaders struggle in real time with staff to solve problems. So we're not absent at 2 o'clock in the morning. We're there to support our teams. And also courageous leadership. There's so many things that can go awry in the process. And it's very important that as a leader that we stay in tune and we're there to support and to help. Because there's, again, many things that can make a donor not be a donor. And we should be there to support our team members to troubleshoot and to help them get through those cases. Content expertise is something that is very important. Best practices are known. We don't really need to reinvent the wheel. Sadly, as I've mentioned before, the best practices that identified that by the Organ Donation Breakthrough Collaborative that happened about 20 years ago may not be in wide use throughout the industry. I know in my own OPO, we had gone away from those, the best practices that were provided in the collaborative. But these practices need to be hardwired into policy and, more importantly, practices. The challenge is how do you do it? How do you implement it? And so I was fortunate to be a part of the collaborative back in the day, and I knew how to actually put some of these things into action. And the first things first, high leverage changes, those are so important. They haven't changed even in 20 years. Really helps us to understand how we connect, build relationships within our hospitals to effect a good outcome, meaning a donor that is converted to an actual donor and organs are used for transplantation and lives are saved. So they don't change, but implementation and accountability for their successful implementation does. We have to hold people accountable to applying these best practices and making sure that they're put in place. And it honestly takes work. So I'm not going to go through all of this, but I think some of the things that we found very important that we needed to put back into our process was early referrals, mastering effective requesting, and the implementation of donation after cardiac death. But first things first, in high leverage changes, if you can't find your packet, call me, email me. It's still out there. It's still relevant today. And I've seen a couple of hospitals now where we have gently added some things, turn a 360 with regards to how they work with us in the donation process. So I think our hospitals want and need to know. I think that we should hold them at a higher level of accountability, and we'll talk a little bit more about that moving forward. But this is very important, and I'm happy to share the change package with you. I had to dig it out myself again, and so I have that available, and I can share that with you again. And then it's focus and work. After you've gone through the benchmarking, after you've established good leadership practices, after you've looked at content and expertise, it's now work, focusing on your work. And so we had in some ways looked at referral volume, authorization rates, hospital and poor process and adverse events, not the way we do today, because we know more today that because we refined our data, but these were our areas of opportunity and focus. I believe at the very beginning, but we did not do it in a systematic fashion that we are currently doing it in now. But we realized that we were wondering about our referrals. We had a huge referral volume, but what we didn't understand, and now we know, we had a lot of referrals that were being missed. And I'm going to go into that with you. And we're also going to talk about authorization rates and hospital process. Where did we decide to place our focus? In these areas that are listed here: increased referrals, OPO and hospital staff reprioritized to focus on the first things first, high leverage changes. And we are still on the journey. So I want to be clear on that. We by no means have arrived. And so I am hoping that I can learn from you today, just as I hope I can share with you some things that we are doing. An increase in the number of authorization rates. And so when you know that you may be missing referrals, the referrals that you do get, that you're able to be in front of families, it was very important that we looked at how we could do better at getting authorization, getting the yes, empowering families to give the gift of life. And that's where we took our focus to as well. And finally, and more recently, we have, oops, I'm playing with my mouse too much. We have restructured staff operations to get closer to donors in our hospital partners. We're still in that process because we recently just went through another realignment. This is not what the talk is about today, but I'm happy to share that with you again. But we realized that we needed to have a more intensive in-person presence and interface between large potential donor hospitals and us. And so it's been challenging because of the pandemic, obviously, but we're working on ways to have more of a presence, because we realize that sometimes missed referrals are due to the activity that is going on in the hospital that we don't have control of, and neither sometimes do the hospitals. They're very busy and we need to be present. We're the ones that need to focus on the donation portion, and we've got to find ways to be better partners with them too as well. So let's talk about referral volume and missed referral. And this is where I am going to have to be a little bit more scripted because this information is very detailed. And I will tell you that if there are too many questions, I may have to interject and allow my guru, Ananda Duda, who should be on the call, to answer some of these questions. But in the history of the opioid industry, we have used denominators like population, deaths, inpatient deaths, etc. But none were granular enough to show us referral volume gaps for an OPO until the calc and the CMS proposed denominators came out in 2019. This really helped us understand referral gaps, which is what I'm talking about today. So I'm just using this to illustrate how we looked at referrals. On the left, we have the CMS proposed denominator, and on the right is the original calc denominator. Both denominators have three common elements. They both have location as inpatient settings, they both have age factor, and they both have cause of death. For CMS proposed denominator, we exclude a list of ICD-10 codes as the cause of death that will make the patient unsuitable for donation. But for calc, it is an inclusion approach. And we have a list of ICD-10 codes, ranges where donation is likely to happen. CMS adopted the calc denominator in their final rule in 2021, but these denominators have been around since 2019, and we have been using them to identify referral gaps and benchmark referral volume. And let me show you how. So this is what we call the CMS calc tram line. And here's a chart that shows both the denominators. The orange line on the top is the CMS proposed denominator, and the blue line on the bottom is the calc denominator for all 58 OPOs. When we collected 2019 referral volume data from 45 OPOs across the country and plotted them on the graph, the yellow squared represents OPO's vented organ referral volume for 2019, and the red squares show the OPO's vented organ referral under the age of 76, where the patients had died. This way, we can show the correlation of an OPO's vented organ referral to the two denominators. This also shows that for our purposes, and you see San Francisco there, that DN West had a referral gap. We had more vented referrals than we were actually capturing. So we created an OPO donation pipeline, and we call it the waterfall model. And I'm not going to go into much detail about this because this is a great way to see and find gaps in the conversion side of the process. So you really follow the trail of, okay, you have 5,800 vented organ referrals, and you go all the way down. And as you can see, finally, the number that we had was 377. We had 5 cases lost after recovery. And, you know, now with the new CMS rule, you have to deduct those cases where organs were not actually transplanted. So although we had 411 donors in 2019, we ended up being able to capture under the new rule 377 that were actual donors. What this does not tell you is how we're doing with our referral volume. It does not show an OPO if they have a referral gap. However, this does. And so referral volume benchmarking is something that Ananda worked on and put together for us. So in order to find referral gap, we took the data we collected from the 45 OPOs that I showed you a couple of slides back and benchmarked them. This tells us how an OPO is doing in terms of their referral volume. The OPOs on the left of the chart are doing better with their referral volume than the OPOs on the right. The referral volume benchmark clearly shows that DN West needs to increase their referral volume. And you see us, we're like at 5% in terms of referral volume, when most people, the industry average at the time was 40%. And so my question was, what are these top OPOs doing? Because there's a correlation here. The same OPOs that are on the left-hand, to my left-hand side, are also the OPOs who are in the top tier when in terms of performance. And so what are they doing different? What are we missing? What can we do? So this last chart was for 2019 data. When we did the same benchmarking for 2020 data, it showed the same thing for DN West, which is an area of improvement when it comes to referral volume. And the 2020 data also shows that the industry in general increased its referral volume. Sorry, I think I was on the wrong page, slide. No, my mouse is not working. Okay, great. And so what this is showing is that we see opportunity here. And over the last year, you can see now we have a higher industry average on referral volume. So again, these same OPOs are in the top tier in the country when it comes to performance. And so although we improved, we are by no means at the industry average yet. And we're continuing to work to see how we can refine some of our current practices to ensure that we move the needle here. And a lot of it has to do with maybe what is the criteria that we're asking the hospitals to call us on. And so we're going down deep into our process to make sure that we are able to look at that. Okay, there is a slight delay here. My apologies. Okay, so the second area of opportunity was authorization rates. And I think what I want to share with you all is that we have made great strides in this area. I think when I came on board, I realized this was one of our biggest opportunities, and our first opportunities was in this area. And so I'm going to share with you some of our slides related to that really quickly. We needed to find a way to own a practice that we all could live with, that was easy to understand, that allowed new people who came into our organization to have a foundation on best practices related to authorization. And in my almost 30 years of experience in the OPO world, very early on, I adopted the dual advocacy model, which has really, to me, been the best model out there yet, because it talks about empowering families, and that is so important. They've lost all control of everything. And so to be able to empower them to make this decision, to leave a legacy, to allow their loved one to be a hero, we only have one chance to get that right. And so I immediately connected with the Gift of Life Institute and started working with them to use that as our model on how we trained our team. We also, something that I had been doing since I was in Houston, was we have authorization coaches. This is an outside person that reviews the overall process, looks for things that the person in the moment may not identify, looks for barriers in donation process based on information we have on the family, cultural, religious, divorced parents, all those things that come up. There are huddles that are mandatory to develop a plan, to reassess at certain points, to pre-assess family dynamics, to be transparent on authorization rates among staff too as well. They work with that. And also using dual advocacy as the model for our training. And that's what we've been able to do there. And so I wanted you to see the progression here. These are non-FPA, non-first person authorization rates. We generally like to track this because most of our opportunity is in this area. When somebody is a first person authorized donor, it's a notification. And we do realize that sometimes we get family resistance from that. But this is an area where these people either may have not heard about donation or have a lot of barriers to donation. And so this is the community, the people that we need to find a way to have that best approach with. In 2018, we were sitting at 37%. And my heart was in my stomach because I thought about so many lives that had been lost. And was it solely because we didn't have the right language? Or was it that I just have a DSA where nobody says yes to donation? I think that my family services team needed to be empowered, needed to have a system that would allow them the access and the ability to huddle on these conversations, to deal with different cultural issues. And we brought that in to help them. We provided these tools to them. And as you can see year to date, non-FPA, we're at 52%. That's a 41% increase in non-FPA authorization from 2018 to year to date. And I'm really proud of the team for the work that they're doing. Although sometimes they think I'm not because I don't share that often with them. I am very proud. But at the end of the day, there is still a sense of urgency to get better in this area we cannot rest on what we've done in the past. We've got to look forward to the future. Every day, more and more people are being added to the list. And every day we need to find ways to reach our community and get that yes to help save lives. As you can see, our global authorization is at 68%. That's a 31% increase. And that shows everything, everybody. This includes FPA. Still got a lot of room. The collaborative wanted us to be at 75%. We're trying to get there. That's the goal. And we even want to get higher. And I've been on teams that have been much higher than that. In Houston, kudos to that team. We were sitting at 80 and 90% some years when I was there. So I know it's possible. It's us getting better at what we do. And I'm encouraged with the progress so far. DCD, wow, we were sitting at 28% in 2018. Look at where we are now. That's a 61% increase in DCD. And we're being very transparent here. We're not where we want to be, but we see movement forward. And so I am, again, truly proud of our team who has gotten us there. And we looked at things as early interaction and making sure that we were being informed earlier about DNR. Sometimes we were just missing the boat. So, I'm going to talk a little bit about the hospital's opportunity to help us, to support us in this process. But, late referrals really set our team up for failure. And so we are working now with our hospitals in a more, I don't want to use the word aggressive because that's not how I want to come across, but in a more systematic manner to ensure that they understand the stakes are high for us. And we need to make sure that we have all the support that we can get from the hospitals in this endeavor to save more lives. This is just a look at brain death authorization rates, non-FPA, again, a 40% increase since 2018, 56% year to date. So again, kudos to the staff. And this is the best slide of all. This is an area where when I came on board, wow, there was just so much opportunity to reach different communities and look at what we've been able to do. And we're not done yet. This is just the beginning. The best is yet to come for us. And as you can see, 163% increase in Native American authorization rate, 56% increase in Pacific Islanders, 70% increase in the African American community, 64% increase in the Asian community, a 23% increase in the Hispanic community, and a 27% increase in the Caucasian. We look at these rates all the time. We're in the process of creating programs that are specific to each one of these different groups of communities so that we can go out and educate them. We did a Giving Me Life campaign that some of you, we've shared with some of you, recently won an award, and we want to use that to help the Asian American community, the Hispanic community. So we're going to continue to push out programs that are specific to the different groups. We're going to create focus groups, and we're going to meet with people in their community and talk about the challenges that they face with making the decision to donate. And that's what we're doing on that side. And then I know some of you have looked into this, but we are also very focused on diligent searches, families that we don't know where they are. And so sometimes it's challenging. Sometimes our hospitals give authorization when there's not family available, but sometimes they say no. And then there is also the ability for the medical examiner to do that. They're not as supportive as they could be. And so that moves us to making sure that we do diligent searches to find these families. And so as you can see, in 2020, we 50 families were found. And we were able to approach and authorize. So this is another area that you may want to look into. We also have a unique way of making sure that we capture the registered donors. Sometimes they're not always registered here. And so there's a little bit of investigation sometimes that goes on to ensure there's a last name change. There are a lot of things. We look to close any gaps that would prevent us from identifying people on the registry and also finding families that we need to approach about donation. So, finally, I want just to talk a little bit about hospital interventions based on data. We found that we have a lot of hospitals that have posed a challenge for our ability to get, donors, to convert donors to actual donors. And after we know our game plan and our focus, then it's really just work. And so this last piece is really going to talk just a little bit about some of the hospital interventions that we've done. Again, some is not a time, soon is some is not a number, soon is not a time. And this was from Don Berwick. We really need to focus in on that one donor that can be denied because of hospital barriers or lack of hospital support. Again, this is hard work. It takes 24/7, 365 days work. It takes passion, it takes discipline, it takes adherence to alignment and all things mission, and it's hard work and it's about results. And so that's very important. And so I've pivoted a little bit because I kind of got ahead of myself, but organ donation rates, we're focused on that top quartile. The new CMS rule obviously is where we want to be, and we have a lot of work to do to get there, but we have a game plan now. We know where our gaps are, and now we're working to fill it. And as you can see from this slide, there has been a huge shift over the last year and a half, where a lot of OPOs who may have been in tier 3, tier 2, are now in tier 1. We've continued to see an increase there. So with that dramatically increasing referrals from hospitals and improving authorization rate, again, I want to end, I think I'm close to ending by saying relentless benchmarking is important. You have to know where you stand. And then when you know where you stand, you can look at those OPOs and you can ask them, you can pick up the phone. I've asked my leaders to call and say, how is so-and-so doing this? What are they doing different from us? It's also a culture change. Accountability for results and higher expectations is really important as you move forward. Building competence in your team members is never ending. We need it, but the hospitals want and also should demand that from us. And so nurturing champions, telling stories, living passion. Passion must always be accompanied by competence. Good intention is not enough. And so when somebody says, gee, sorry, we got so busy, we forgot to call, that's an opportunity. Those can be lives lost. And I will tell you that we've had those calls before. And a lot of times those calls that were missed were people who had already made their intention known. And it's the law that we follow through when someone says they want to be a donor. And so what a travesty to know that we did not follow through on that person's wishes. Consistency, showing up, hard work, and engaging tension. And that's something that we all struggle with, but sometimes we have to engage tension to get to where we need to be. It's about saving lives. And so every conversation is not going to be nice and loving. Sometimes we have to be direct, and we have to make sure that everyone in this circle or this sphere is being accountable for the part that they play. And as I said earlier, donors are in the hospital. Hospitals are very critical to this process. I think I went too far. So there was one question that I wanted to answer, and then I'm gonna hand this back over to Amanda for further discussion. Why does CMS see OPOs competing against each other as productive? And so CMS made their intention clear. They have seen OPOs that have gone through the different processes, and as you all are aware, an OPO that I know of has not necessarily been decertified. But I think they believe a competition process whereby all OPOs have sufficient incentives will help us to cluster towards towards the top, being in the top tier. And so I think what they're trying to drive is, I don't know that the word competition is something that they should have used. I think we did this same work in the collaborative, using collaborative as a word, working collaboratively, we were able to achieve astronomical results. And I think that if we stay focused on what we did with the collaborative and continue that, and not so much wordsmith CMS's comments, but look at how we can drive change using the way that we've done it in the past, I think we'll go further. And so this slide here, I want to share with you because I do feel like, I think when the CMS final rule came out, all of us had some angst and were concerned about how we would end up, and that perhaps a lot of OPOs would end up being decertified. And the jury's still out, I understand that. But how is volume trending now in the industry? We're seeing the national trend of more OPOs adding significant amounts of donor volume as a result, and more OPOs are congregating in tier 1. And so in 2019, and this is CMS published data, there were 27 OPOs in tier 1, 15 in tier 3, and 16 in tier 2. In 2020, which has yet to be published, and I think we're still waiting on the transplantation rate, which we currently don't have yet, there were 28. So more and more OPOs. And in 2021 through May, on the donation rate alone, it appears that there are 37 OPOs in tier 1 and only 4 in tier 3. CMS said the competition will drive OPOs to improve their performance, which will result in them clustering towards the top, on a three-tier system. We are already seeing that happening. And as you can see from the table on the left, there were 15 OPOs listed in tier 3, and now we're down to 4. This projection is based on donation rate only, as we are yet to get the data and clear instructions on how to compute the transplantation rate. And I hope that we get that soon, because I think it will help us understand where we're at and how we can perform. Fortunately, we are still using some of the old metrics to keep track of things internally. And so we kind of know where we're at, but we're looking forward to getting the final information. But more and more OPOs are clustering in tier 1, and that's great to see. I think everybody has looked to see how they can refine their processes, and what I'm seeing is great. And I hope that we can share some more dialogue related to that. But that's what I think is happening in regards to that. And as you can see now, in 2019, I mentioned it, there were 37 OPOs in tier 1. And again, some of this data is without the transplant rate denominator. So again, this is only on the donation rate, which tells you that we're doing more and more donors. Okay, and this is January through May of this year. And this is showing where all the OPOs, again, organ donation rate. So thank you so much for your time. I've really enjoyed sharing our journey, and I'm going to hand it back over to Amanda for any questions.
Right, before I turn it to Amanda, I just want to remind everyone, if you do have any questions for Janet, you can go ahead and submit them using the Zoom chat feature. For anyone that may be new to Zoom, that's going to be located at the bottom of your screen in the navigation bar. And so with that, I'll turn it back to Amanda.
Thank you, Janice, for the interesting presentation. So beneficial, and information was through the roof. So thank you. We do have a question in the chat box from Dustin Goad. To answer your second questions, the slides will be available after the presentations, but his main question was, are the authorization coaches looking for real-time approaches or after the fact?
They are involved in real-time approaches. They are contacted prior to interactions with families. There are times where, there's no time to do that, but we try to monitor our referrals and know where the hospital is at in the process so that we avoid those impromptu interactions with families. We found that it's not as helpful as it is if we're able to have a planned approach. So we try to make sure that it's in real time and it's a planned approach.
Okay, thank you. We have a couple other submitted questions. How has the data helped drive this initiative that you roll out to your hospitals?
Wow. So data is everything. We really don't take an inch without looking at our data. It's really what's driving our results, knowing where our gaps are. And I think it's important to, if I'm hearing your question correctly, you want to know how it's been helpful with our hospitals. We've been sharing dashboards with our hospitals for quite some time, but I don't think they're effective. And when the final rule came out, we are in the process currently of revamping our hospital dashboards and changing the conversation to more of, hey, how can we help you all get better in this area, and really focusing on their gaps in the donation process too as well. The challenges that we face right now is that the conditions of participation, so the hospital's requirement to support us, have not been updated since 1988, I believe. And if I'm wrong, someone can correct me. And there is a huge need for there to be an update. It currently is not aligned with our new metrics that we're held accountable to. And I think that there's going to need to be some changes to that in order for us all to be successful, because if the hospitals don't call us, there are no donors. And so I think it's important that we look at that too as well. They're outdated. There has not been any recourse or anything done to hospitals that, blatantly don't call us on referrals, and we lose donors. And, it's all about every donor. It's about the one. And so that can add up very quickly if it's just one or two. And, in all of the hospitals in the United States, if everybody decides to miss out on calling us, it's not going to help donor volume. And we can be as great as we want to be on our side and be held accountable, but there's joint accountability here in order for this to really work.
Kind of referencing back on those memorandum of agreements and just the overall census of who this information is getting out to, how did you introduce the updated metrics to the hospital's leaderships, the CEOs, the C-suite?
So what I did was back in February, when I sent out an email to all the CEOs, CNOs, COOs in our service area and let them know that there had been an update on our metrics and how they could support those and what we would be doing differently. Meaning adverse events would be looked at very closely, and we were going to create a more formal way of reporting because we were being forced to be held to a certain standard, and we can't do that without our hospitals. And that was followed by several town hall meetings where I went into more detail about what our new requirements were. And we also had some discussions and questions, and it was interesting. I had some people that weren't really excited about the directness and maybe in their minds the threat of reporting, but it wasn't meant to be a threat. It was, hey, we can't do this without you. We're going to need your help. And I need to be able to tell CMS, well, I could have had 500 donors, but I had 100 donors that were blocked because of hospital processes, et cetera. I need to be able to show that we're doing our part, but our partners are not as willing. if that's the case. And so it was pretty interesting, got a lot of support, have a lot of hospitals that want more information and want to look at their donation system overall and make it better. And I think the majority, that's how most people felt.
Thank you. Oh, we have a couple more questions coming in through the chat. Circling back to the authorization, Barry Massa wanted to have more information regarding the authorization coach. Is this a person, an OPO employee? What's their skill set? Any information regarding tips?
Skill set, yes. I have two consultants that work for us as authorization coaches, and they have a track record. They've actually been family resource coordinators, have sustained authorization rates of 80% or greater, and have worked within various OPO systems and have that deep knowledge of culture, interactions, and things that happen. And so they are not full-time employees with our organization, but they are consultants that work daily with our teams to help with cases. The idea long-term is to possibly have that in-house. But when I came on board, I was searching for a way to close some gaps fairly quickly. And so we're still in that transition. The goal is 75%. As you can see, we're close, but we're not there yet. But that's how they work within our organization.
Thank you. We have another question from Leslie Soffarelli. Are OPOs using the CMS authorization percentage as their performance measure or the actual authorization percentage? At her OPO, they are evaluated on CMS and actual, but actual is how performance is measured.
I'm not sure I understand that quite yet. So CMS, I think, looks at, I showed you global and then I showed you non-FPA. Global means it includes the first person, authorization. Non-FPA obviously means that it does not include it. And so we use that to look at our team members, because we feel like when somebody has already chosen to be a donor, although we do have challenges sometimes there when the hospital doesn't support the donor who has made their wishes known. We feel like the biggest challenge is on the non-FPA. And so that's what we use to evaluate our team members. But we give credit to the overall process because there still is work that has to be done even on the notification side.
Oh, we have another question from David Dyer. The OPOs are held to a standard of number of donors with transplanted organs. Transplant centers are penalized if they take more than marginal or donors that have lower survival rate. Would you have any suggestions for how to bridge that gap?
Actually, no, I do not. I think it's a conundrum. Again, I did support the final rule, but I do have some concerns about some of the things in there, because we can package and label an organ beautifully and send it to the transplant center. But if there's some changes, if their recipient becomes ill and doesn't receive it, and maybe they don't call us and we're not able to find another home for it, it actually puts us in a box that I think there should be joint accountability here, because I can ship you the organ, but I can't make you use it because of the very things that he said there. And I don't know how we can connect those dots, but we need to. And that was one thing in the final rule that was a little disturbing. I understand what they're trying to get at, but at the same time, I don't think that we should be solely responsible for that. But that's the way it is. And we're working with our transplant centers to, what we've done is our allocation team and those that are in the process of placing organs are making sure that we back them up. And we're also notifying the transplant centers if something changes, please let us know, because we do have another home. So we're trying to mitigate any type of loss in that area to work with that part. But that is a sticking point for me in that area.
Okay, we have a submitted question. What long-term action plans have you put into place to sustain your performance?
So I don't know if you saw, because I was trying to rapidly go through my slides, but we sustained it through 2020. But I really feel like we are a 500 or better OPO, and so we are looking at some strategy. We're constantly looking at what we need to focus on right now. We're looking at discards as one of our areas of focus. We're looking at missed referrals. We're looking at authorization. We're looking at how we're doing in our pediatric donation area too as well. So we have 4 or 5 things that drive us, and it's by looking at our data. And so referrals, as I mentioned, is a big one for us, and we continue to look at that. And then again, reworking with our hospitals on how to make sure we don't miss out on a donor.
We have another submitted question through the chat from Chris Wright. What was one process change that had the most impact on migrating your missed referrals?
So as I mentioned earlier, we're on a journey, and I think there's a couple of things that are causing that. And in the middle of us identifying where our opportunities were, the pandemic hit. And so we were receiving, some of our hospitals called us and said, hey, due to the pandemic, we're not going to call you on donors, and we were like, yeah, you still have to call us. People are still dying. We're doing transplants, et cetera. And so that's a little muddy right now. But what we do know is we're looking at the vented referrals that come into our organization, how we're triaging those. We're looking at timing. We're looking at how we notify hospitals when, hey, you called us a little late, kind of set us up for failure. We're looking at how we can be a little bit more real time in dealing with those type of events. So I don't know that there's just one thing. Well, I will say, I will take that back. There is one thing. I did not feel like when we got the call and the donor met the criteria that we were there. We were actually at the hospital. So the first thing when I got on board was when they call, they make criteria, we go to the hospital. So that was probably an area where it wasn't very clear to me, and we were selective on when we were on site. And so that may have been the one thing. But since then, that has been established, but now we're faced with other things like the lateness in the call or even the missed call. So we're still working through that.
Well, thank you. Thank you for your time, Janice. Truly fantastic presentation. I'll turn it back over to Deanna now.
Thank you so much.
Right. Thank you, Amanda. And thank you, Janice. I just want to echo Amanda's sentiments. Truly fantastic presentation. I think a lot of valuable insights for the community to take away. So I so appreciate you taking the time to join us today and to put together today's discussion. Amanda, thank you for doing a phenomenal job facilitating all those questions. For anyone that may have any additional questions, feel free to submit them. We'll follow up with Janice and try to get those responses out to you. But in the meantime, enjoy the rest of your day. And thank you so much for joining us. Bye, everyone.
Bye-bye.